Hi everyone, my name is Leonard and today I'll be demonstrating the preparation involved when performing a drug-facilitated intubation. Conducting a pre-intubation airway assessment can assist in identifying patients who have difficult airway anatomy or other characteristics, which may make managing their airways challenging. Pre-intubation airway assessment should look at more than just the predictors of difficult intubation. In fact, according to the Australian and New Zealand College of Anaesthetists, an airway assessment should investigate the potential difficulties at every stage of airway management, including BVM ventilation, supraglottic airway insertion, tracheal intubation, and infraglottic or surgical airway insertion. After all, some intubations may require using all four of these interventions, and it is therefore crucial to identify factors that make performing any of them difficult. This is extremely important to allow for early strategic planning to improve first-pass success, reduce the risk of complications, and if needed, make an informed decision to not proceed with intubation altogether. So how do you assess each of the four components of airway management? Well, unfortunately, there doesn't appear to be a single universally recognized test that can accurately predict difficulties at every level of airway management. Instead, various mnemonics exist that each focus on one component of airway management, like MOANS for BVM ventilation, RODS for supraglottic airway, LEMON for intubation, and SMART for cricothyroidotomy. For today, let's focus on how to predict difficult intubation by direct laryngoscopy using the popular mnemonic LEMON. L stands for look. After applying appropriate PPE and checking for dangers, walk up to the patient and look at the external features. Quite simply, if the airway looks difficult, then it probably is. Some particular physical signs that may be indicative of a difficult airway include facial injuries, bleeding, and a short neck. E stands for evaluate using the 3-3-2 rule. Within the 3-3-2 rule, the first three evaluates adequate mouth opening. To do this, check that the patient's mouth can open to accommodate 3 fingers. The second three evaluates whether the mandibular space is large enough to allow proper displacement of the tongue during laryngoscopy. To do this, check that the distance between the tip of the mentum and hyoid bone can accommodate 3 fingers. The 2 assesses the position of the glottis in relation to the base of the tongue. Check that the distance between the hyoid bone and thyroid notch can accommodate 2 fingers. Less than 2 fingers can indicate an anterior larynx. M stands for Mallampati score, which is assessed by getting the patient to open their mouth as wide as possible while protruding their tongue. An inability to visualize oropharyngeal structures indicates a difficult intubation. O stands for obstruction and obesity. Apart from visualizing an obstruction, it is important to take note of changes in voice, difficulty swallowing, dyspnea, and stridor. N stands for neck mobility. Check that the patient can flex their neck and extend their head. Inability to perform this due to a diseased vertebral column or spinal precautions can make viewing the glottis by direct laryngoscopy very difficult, and therefore video laryngoscopy should be considered. Despite the obvious benefits, airway assessments still have limitations and implications. Firstly, it may not be possible to perform some of the assessments in the pre-hospital setting because of reduced GCS and compliance. Secondly, the individual airway assessments, even when used collectively, are not 100% sensitive or specific and will therefore incorrectly suggest that an airway might be easy or hard when it is in fact the opposite. Thirdly, the dangers of taking excessive time to perform each of the 4 mnemonics of LEMON, MOANS, RODS, and SMART needs to be weighed up against the dangers of not performing them at all. Physiological optimization starts with appropriate positioning. The patient should be positioned so that the external auditory meatus is in line with the sternal notch. For most patients, this will require placing them into a sniffing position, which comprises of flexion of the lower neck and extension at the atlanto-occipital joint. Other patients, including those who are obese, may need to be ramped. Aligning the external auditory meatus with the sternal notch helps to optimize patient physiology and intubation success for several reasons. Firstly, it can dramatically improve upper airway patency. Secondly, it decreases airway resistance and therefore improves airflow. And thirdly, it significantly improves laryngeal view during direct laryngoscopy by bringing the oral, pharyngeal, and laryngeal axes into closer alignment. If possible, the patient should also be placed into an inclined position in order to improve greater view and first-pass success. Furthermore, when it comes to optimizing patient physiology, evidence suggests that an incline of at least 30 degrees improves functional residual capacity from 2.1 liters to 2.91 liters. Pre-oxygenation is the administration of oxygen to a patient prior to intubation in order to extend the safe apnea time. The safe apnea time is the time it takes for the apneic patient to desaturate to critical levels, which commonly correlates with an SpO2 of 90%. When pre-oxygenation is performed effectively, A healthy individual can have a safe apnea time of up to 8 minutes. This is extremely important when attempting intubation, as inserting an endotracheal tube can be an unpredictable process and may require multiple attempts. So how does pre-oxygenation allow someone who is not breathing to maintain normal oxygen saturations for so long? Simply put, pre-oxygenation increases oxygen stores in various body compartments, including the tissues, blood, and lungs. The lungs in particular have a large capacity to hold extra oxygen via a mechanism known as denitrogenation, which occurs when nitrogen within the lungs is replaced with oxygen. Now that we understand the importance of pre-oxygenation, let's talk about how to actually perform it. After checking for dangers, applying PPE, and correctly positioning the patient, a bag valve mask should be applied. A good mask seal is vital, therefore a 2-person BVM technique using either the double EC or thinner eminence grip is recommended. The next step is to ensure that the oxygen flow is adequate to achieve an FiO2 of as close to 1 as possible. In Ambulance Victoria, we currently use the AmbuSpur 2 BVM. There are several ways of increasing the oxygen concentration beyond room air using this device. Number 1 is to attach a demand valve which will supply 100% oxygen and prevent room air being entrained into the device. With a good seal, it is technically possible to deliver an FiO2 of 1. Number 2 is to attach the reservoir bag. It is important to note that the device will entrain room air if the patient's minute volume exceeds the reservoir capacity. Therefore, at least 15 litres a minute of oxygen should be applied. A PEEP valve should also be attached and start at 5 cm of H2O. Positive end expiratory pressure, or PEEP, is important when pre-oxygenating the patient for the following reasons. Firstly, PEEP increases functional residual capacity and therefore maximizes the oxygen storage capacity of the lungs. Secondly, PEEP helps prevent atelectasis and shunt formation. Also, if a second source of O2 is available, nasal prongs at 15 litres a minute should also be applied early and left on during the intubation attempt. This is referred to as apneic oxygenation and has been demonstrated to prolong safe apnea time. In terms of how long pre-oxygenation should occur for, evidence suggests that at least 3 minutes worth of tidal volume breathing or assisted ventilation with a high FiO2 source should provide close to maximal denitrogenation. The sedative agents used in drug-facilitated intubation are known to cause hemodynamic compromise. Opioids like morphine induce histamine release and subsequent hypotension. Midazolam, even in low doses, reduces systolic blood pressure by 10%. In addition to sedative agents, depolarizing neuromuscular blocking agents, such as succinylcholine, can also cause bradycardia and subsequent hypotension by binding to muscarinic receptors in the heart. Therefore, regardless of the specific medications used, the administration of crystalloid fluid such as normal saline is indicated before any drug-facilitated intubation. This is known as pre-hydration and is essential to compensate for anticipated vasodilation and hypotension. To perform this, insert an appropriately sized cannula, usually at least an 18 gauge if possible. Auscultate the patient's chest to ensure there is no evidence of acute pulmonary edema, which may be worsened by additional fluid. If there is no evidence of APO, administer 10 ml a kilo of normal saline. The scene layout at a drug-facilitated intubation can vary significantly depending on a multitude of factors relating to the patient, crew, and environment. If a decision is made to intubate a patient on the floor, it may be appropriate to elect for an extended floor setup. As the extended floor setup involves so much equipment, it is important to lay the equipment out in a logical manner. Taking the perspective of the intubating paramedic at the head end, on the left-hand side should sit the laryngoscopes. There should be a size 3 and 4 Macintosh laryngoscope, as well as video laryngoscope. The reason for it sitting on the left-hand side is because laryngoscopy is performed with the left hand, thus making it easier to locate and pick up. On the right-hand side of the patient's head will be the remainder of the airway equipment, which should be laid out in the order in which you may use them. That is, start with what you know will definitely be needed, such as the endotracheal tubes, and then place the remainder of the equipment in the order in which they appear in the difficult airway guideline. So here we have the predicted size ETT plus 1 size smaller. Next is the stylet and bougie, which may or may not be utilized depending on the airway anatomy and grade of view. There's a 10 ml syringe to inflate the cuff and tube tie once tracheal placement is confirmed. What follows is the equipment that will be utilized if intubation is not possible, including an OPA, which is also used as a bite block, an MPA, supraglottic device with gel, and cricothyroidotomy kit. Colorimetric capnometry, McGill forceps, and gastric tube kits can also be placed on this side. Close by will also be 2 oxygen sources if possible. one for the BVM and one for nasal prongs. Suction should also be tested with the suction catheter placed in an easily identifiable location, such as just under the patient's right shoulder. On the left side of the patient's torso is the monitor. It has been positioned here to allow all paramedics on scene to easily view it. Non-invasive blood pressure, ECG, SpO2 and end-tidal CO2 should be monitored continuously. On the right-hand side of the patient's torso, near vascular axis, is where the medications are placed. Vascular axis should comprise a 2x18 gauge or larger if possible. If unable to attain venous axis, IO should be sought. Required medications drawn up into syringes will include sedation, paralysis, both for induction and long-term, atropine, as well as inotropes such as adrenaline, 1 in 10,000 and 1 in 100,000. There will also be 2 syringe drivers, one with post-intubation sedation and the other for an adrenaline infusion.